Доброго дня всім! Ми розпочинаємо наш ефір з Генрі Маршем. Це наш вже третій ефір, в якому бере участь Генрі Марш. І я попрошу відкрити цей ефір пана Андрія Myzaka, без якого не було б взагалі ніяких ефірів з Генрі Маршем. Тому, пан Андрій, ми вам дуже вдячні і просимо вас відкрити цей. Дякую.
Вітаю, друзі. Я доктор Андрій Myzak. Насамперед хотів подякувати нашій інституту Катерині Булавіновій, без якої б цих ефірів також не було б без її ідеї провести цю серію. І хотів би подякувати Генрі, який, незважаючи ні на що, працює з нами, з українцями, і не хоче покидати своїх друзів самотніх ці дні, місяці і роки тяжких випробувань. Сьогоднішня наша розмова присвячена дуже болючій і актуальній темі медичної освіті в медицині, тому би я коротенько хотів би розказати про свій досвід, як я це все бачу, і розказати, скажімо так, український вимір цієї справи. Коли ми говоримо про освіту, то ми говоримо про тривалий процес навчання, якого є актори, це вчитель і учень. Серед молодого покоління завжди знайдуться молоді і амбітні, які захочуть стати професіоналами. Але їм потрібний об'єкт для наслідування, рольова модель. І тому на передній план в ситуації з навчанням виходять вчителі. Які ж у нас вимоги до вчителів? Вчителі найперше мають відповідати двом основним критеріям. Перший критерій, як це зараз прийнято казати, це hard-skills, другий soft-skills. Якщо ми говоримо про hard-skills, то ми маємо не забувати, що медицина – це насамперед звичайне ремесло. І вчитель має за свій священний обов'язок ділитися зі своїми підмайстрами, якщо ми говоримо про стосунок майстра, вчителя і підмайстра, всім досвідом своєї праці, який він здобув за роки роботи. І всіми своїми навичками має вчити молоде покоління. Але що не менш важливо, коли ми говоримо про софт-скіли, то вчитель має показувати своїм власним досвідом і формувати у своїх учнів ціннісне, філософське, культурне ставлення до професії і до головного об'єкту професії, до пацієнтів. Пацієнти не мають розглядати як джерело збагачення лікарів, або пацієнти не мають належати до категорії «вони». То ми лікарі – це ми, а пацієнти – вони. Основним критерієм, основною культурною філософською цінністю, на мою скромну думку, має бути розуміння, що турбота і піклування про пацієнта – це не є обов'язок лікаря, нав'язаний суспільством, а це великий привілей, який покладається, який є даром, який дається лікарям. І цей привілей треба цінити. Ось так коротко, але я сподіваюся, що пані Катерина і доктор Марш розвинуть цю тему детальніше і глибше. Дякую, працюємо.
Дякую, пан Андрій. So, Henry, we are all ready. You can start and share your screen and we disappear from the screen.
Right. I'll just speak. Hang on, where are we? Right, share screen. Right, just a few words about. Good morning from London, where it's a beautiful sunny morning. A few thoughts and questions about medical education. Now we all know that the practice of medicine requires a lot of technical knowledge and skills. Traditionally, anatomy, physiology, pathology, pharmacology. And if you go into one of the practical specialties like surgery, you need to learn how to operate. But you also, to be a good doctor, you also need human skills. You need to understand your fellow human beings, not just your patients, but yourself as well. And you need to be able to cooperate with colleagues, because modern medicine is 100% a team effort, not just with the nurses and the cleaners and the porters, but with your medical colleagues as well, if you are going to practice safe, good medicine. You need strong ethical values, because so many decisions in modern medicine are about quality of life and also about cost. And you need emotional resilience. We often have to bear witness to terrible human suffering. We will sometimes make mistakes and have to live with the consequences. And you need to be emotionally strong without becoming inhuman and brutalized by what you see and do. Why is it not moving? Hang on. So a lot of these problems on a human side, and I'll come back in a moment about how do you teach and train such human skills, is a sort of balancing act. We have many competing pressures, competing needs, whatever sort of doctor you are, perhaps with the one exception of pathologists who don't deal with face-to-face with living patients. And you have to find a balance between being compassionate, kind, caring, and being detached. If you become too involved emotionally, it's impossible to do the work. You'll make bad decisions. We all know how, as doctors, it's very difficult to treat members of our own family. It is better to have a colleague to do it because we are too emotionally involved. At the same time, we can become too detached and stop caring and become inhuman. We need to find a balance between being ambitious, egotistic individuals and working as members of a team. We need to find a balance between what we think is best for our patients and a certain amount of loyalty to the institution, even obedience. We need to find a balance between is medicine a vocation, we do it out of love for our patients, or is it a question of making money? We do it out of love for money. Obviously, it's a bit of both, but that again is a difficult balance we have to find. We have to find a balance between being self-confident and certain with our patients, but being endlessly self-critical, so that when there is a bad result, whatever sort of medicine we practice, rather than go like that and hide our eyes or say, well, it was inevitable, we couldn't help it, we need to say, could I do things differently? What will I do differently next time? We need to find a balance between being honest with patients and realistic, but at the same time giving them hope, because hope is one of the most powerful drugs we have as doctors. And if you're a surgeon, you have to find a balance between being brave and being reckless. If you do a very dangerous operation, is that bravery or stupid recklessness? And finally, we have to find a balance between work and life, between the demands of our family and between the demands of our work. All these areas are very difficult. When you reach my stage in life with a long career to look back on, I understand that this is where I made mistakes. These human skills I had to learn painfully. And these are much more difficult skills to learn than simple anatomy and physiology and how to operate. So there is this word empathy in English, which means to feel somebody else's feelings. And it is often said the doctors are not empathic, they're cruel, they don't care for their patients. And of course, to some extent, empathy is hard work. You get emotionally involved and feel to some extent what your patients feel, it makes the job much more difficult. In other words, we can care too much for our patients, and we can also care too little. But the important point is in modern medicine, so many medical decisions now are about quality of life, not simply if we treat the patient, they will live, if we don't treat them, they will die. They're about quality of life. And if you cannot communicate well with your patients, if you can't understand their point of view on what they feel, you will not help them make the right decisions. So that really is all I want to talk about in general terms. Now, let's come out of that. The problem is, how do you teach these medical skills? Medicine has changed a lot. We now have the internet. So the idea you need to learn, memorize huge amounts of information is really no longer the case. It's all available on a laptop, on a computer screen instantly. Almost all doctors now are specialists. The only true generalists left in medicine are family practitioners. In terms of hospital medicine, we're all specialists. And most of what we learn as medical students, in fact, is irrelevant to what we practice as doctors. I mean, as an extreme example, psychiatrists don't really need to know any anatomy. And even then, as a surgeon, you have to learn your anatomy all over again to actually operate. The surgical living anatomy is profoundly different from the anatomy of dead bodies, which we learn upon as medical students. And of course, the tradition of dissecting dead bodies, its emphasis on anatomy, is really historical. It goes back to Vesalius, the beginning of modern, more scientific medicine. As I said earlier, many of the problems you have to face in medicine are about quality of life decisions for your patients. It's about decision-making. It's about the use of evidence. And even with undergraduate training, we need to think how much of the traditional curriculum of very detailed anatomy, lots of physiology, is it really relevant to the practice of medicine? I have some doubts about it. I do not know how traditional medical education still is in Ukraine, but certainly in the West, the emphasis is increasingly on training the doctors of the future to think critically and solve problems, not just to memorize great big stacks of information, to learn to look at the literature, to read it, to think critically, to understand whether a drug trial is valid or not, to look critically at evidence. My own view is that that is a much more important skill to train now than lots and lots of traditional old-fashioned anatomy. So much for undergraduate education. If I understand it correctly, correct me if I'm wrong, postgraduate education in Ukraine is a mess. In most of the West, in all Western countries, postgraduate education is organized nationally. There is a curriculum program of 5 to 6 years of specialist training once you complete medical school. The system I know most about, of course, is surgery. Surgery is a practical craft. You learn it by doing it. You learn it on the basis of a master and apprenticeship relationship. In England, I don't know about other European countries, the selection of young doctors for surgical training is done nationally. Senior doctors do not have any say in who their junior doctors will be. It is arranged on a national basis. Basically, there is an examination, and the young doctors who do best can choose which department they want to work in. 30 years ago, I would choose my own young trainees. I was very critical when I lost control of that, but in fact, it's fine. It works very well compared to the Ukrainian system, where it's so much still the professor's son who is the apprentice, or you have to pay large sums of money to get into a professorial department. This clearly is highly unsatisfactory. But how you change that in Ukraine, you tell me. I mean, only Ukrainians can solve Ukrainian problems. And clearly part of the problem is that medicine in Ukraine is still a bit of a gerontocracy. It is still run by older people who have a vested interest in keeping it as it is. So I think change in postgraduate training in Ukraine, although so very important, will be a pretty slow and gradual process. And that is all I'm going to say by way of a short talk, Katya. So I will stop sharing and we can have a conversation.
Yeah.
Correct. There we go.
While you were talking, there was a comment from one of the viewers, from Nina Dimonenko, who says that unfortunately, in my experience, I understood that our professors and teachers didn't want to teach us because they saw us as a potential competitors. So that's why we had to understand everything by ourselves, and it was very difficult to get access to the operation room. Can we touch a little bit this thing about the competition and education? You did it in one of the interviews, but I just want to go back to this again.
Well, first of all, there's an economic element to it, because doctors in the state sector are paid so little by the state. They depend upon, let's call them, informal co-payments from patients, and therefore senior doctors are in competition with each other. In countries like Britain, we're all paid enough once we are senior doctors. We're not very well paid, not as well paid as in America, but paid well enough that on the whole, there is no competition in the state sector. There is private practice, and sometimes surgeons are competing there, but on the whole, there isn't this major economic pressure to keep your surgical secrets and reserve them only for members of your family. It's also, of course, a hangover from the Soviet system, where the only people you could really trust were members of your own family and close friends, just as Putin is now elevating members of his family in Russia. And that's deeply ingrained, this distrust of the state and wanting to keep everything within the family. In England, of course, it's called nepotism, and it's disapproved of, although occasionally the sons of neurosurgeons become neurosurgeons. On the whole, it's a disadvantage to go into your father's profession. People look at you and say, oh, isn't that a bit corrupt? So I don't know how you change that in Ukraine, but there are obviously deep underlying financial pressures that are partly responsible for it. I think it's tragic. I mean, I think it's very, very difficult for enthusiastic young doctors in Ukraine to get trained properly. It's terrible.
Let's say you are a postgraduate now in Ukraine, and let's say you go, for example, for surgery for children, for adults. And the system is not so good, so you cannot count that the program is really written so well or you will be taught well. How can you help yourself? What should your individual plan look like?
You have to learn English, because English is the international language of medicine. You cannot really make real progress without, and I don't read Russian or Ukrainian, alas, but my impression of the textbooks I've seen is they're not very good compared to what's available in the English language literature. And of course, there's a vast amount of information on the internet. So learning English is the first point. The question then is it worth going abroad, going to the West? Well, there are two problems with that. It's difficult to get a proper training post. These are very competitive jobs. It's possible, but difficult. And simply going as an observer, where you don't actually treat patients, you just watch. It's interesting for a few weeks. You realize how different things can be, but there's a limit to how much you actually learn, just as an observer. But I still think it's a good idea to go abroad as an observer, if only to see a different way of doing things, and not usually a better way of doing things. But then, of course, if you come back to Ukraine, it may just fill you with despair that things are not going to get better. Or at least it is so difficult to make things better.
Anything else? How do you do your own plan of education?
I've been trying to help colleagues in Ukraine for many, many years. Again, with the internet, it's an invaluable way of contacting people. Over the years, I've tried to help giving opinions about brain scans, giving advice. So one of the advantages of going abroad for a while is if you make friends, you may be able to make contacts who will be able to advise you on difficult problems and cases when you are back in Ukraine. It's very useful to have good contacts in the West with other doctors.
While talking about undergraduate studies, you were talking about relevance, and then you said three things like solve problems, think critically, and use the evidence. These three things are not in Ukrainian way of in medical education. So is it a separate, because critical thinking in my own understanding, it's like a separate even discipline or separate way of, training or separate way of discussing with your teachers when they teach you how it looks like and how you can use it. The same as evidence and solving problems. How is it for the moment built in British system, and what do you overall think about this?
Varies from medical school to medical school, but in some of the medical schools, it's the same in this whole problem-based learning comes from McMaster University in Canada. You basically, rather than standing up giving a lecture with lots of facts, you give the students a problem, a clinical problem, maybe a real patient, maybe a theoretical patient, the patient's symptoms, and say, go away and work out what's wrong, and then come back and we'll discuss it. And I find that was partly how I was trained. So it is sort of critical thinking, but learning basic stuff at the same time. I was speaking to somebody when I was in Ukraine recently who said that it had been tried somewhere in Ukraine and it was a disaster. It just didn't work. But maybe it wasn't tried properly. I don't know. But the emphasis being on making the students into active thinkers and researchers, not just passive recipients having to swallow vast amounts of facts, most of which will not be actually relevant to what they actually do when they're doctors.
Evidence. Why this concept is so much not digested in Ukraine, and why it's much more a tendency? I am here a big professor, I did this, and my experience showed that this works, and whatever your evidence is bullshit evidence. So why this concept is so...
Well, because Ukraine is still, the medical system there is still very hierarchical, with an emphasis on authority and people in power, which is the wrong way around. It's what's important is I mean, yes, expert opinion is evidence of a sort, and there are lots of problems which are not answered by clinical trials and strict evidence base, but a lot of problems are, and is also being, as I said, one of the balancing acts as doctors we have to do is to be self-critical and always think, could things be done differently? Is there another explanation? There's a tendency, I still teach when I'm in London every morning at my neurosurgical department, and we look at the emergency admissions, look at the brain scans, and discuss them, make a diagnosis, and decide what should be done. This is all in prospect, so we don't know what the final answer will be. But I'm always saying, when you look, for instance, at a brain scan or any diagnostic process in medicine, it's a mistake to try to be right every time, to try to get the right answer first time around. The really important thing is to think critically, to always think of the differential diagnosis. What are the various possible explanations of the symptoms or the abnormality on the scan, and then which is the most probable explanation, rather than jumping in, which I tended to do. We all tend to do it. Oh, yes, I know that's such and such. Well, quite often you're wrong. In fact, it's something else. So that, to me, is what critical thinking is about, and looking at evidence. It is thinking slowly and carefully about the patient's symptoms, about signs you find on examination. It's a wonderful process of storytelling. This is what I find so fascinating about diagnosis. but storytelling, always thinking about the different possible stories for different explanations. And I don't know if that's taught very much. And if you have an authoritarian system where the professor knows best, the professor is always right, you will end up making quite a lot of mistakes, because it's human nature to get things wrong. And so often in medicine, the evidence is ambiguous and not entirely certain.
You mentioned the expression quality of life.
Yes.
You can talk to doctors multiple times using this expression in Ukraine, but however, if nobody understands what it is exactly and what are we talking about, it's a bit useless to talk about it. For example, for a lot of people after the difficult Soviet times and especially hungry 90s, when they say quality of life, they think about food, repair works in the house, good car, something like that. So when you say quality of life, meaning the quality of life of a patient, what it is for you?
For instance, if you have a cancer and you have a choice between, cancer with a poor prognosis, and you could have more chemotherapy, which probably won't make a big difference, but it might help. It has many side effects, and we all know many patients who have terrible side effects from chemotherapy, and it doesn't make much difference. It's a quality of life. If you're doing something which will prolong somebody's life, is it life the patient will enjoy and find worth living? Now, I agree that depends on their social circumstances, their family, how much money they have. But I mean, you can't, when you make medical decisions, it's not life at any cost. It's more life, but is it worthwhile life? We all accept if you see a 90-year-old with a cancer, we probably won't do anything, although in America they would. But at what point do you say, well, actually, we should stop, it's not worth going on treating? That's what I mean by quality of life.
But if we take not such an extreme example, when you choose between life and death, like with cancer, can you give some more examples about quality of life and probably some differences, cultural differences?
A simple one in neurosurgery, you see somebody with a disc prolapse and severe sciatica, severe leg pain. Well, if you wait long enough, they will get better. But if you operate, you'll get them better more quickly, but there is a small risk of making them worse. Now, that's a quality of life issue. Only the patient can tell you whether the pain is so bad, they don't want to wait longer, and they accept the small element of risk of surgery. And there are many decisions in medicine like that, where you have a choice. Not that it needn't be life or death. It can be a question of pain problem. Again, I can only speak from my own area, but the terrible pain of trigeminal neuralgia, which people would want to kill themselves with it sometimes. It is so bad. And there's an operation, which I specialized in doing, which would almost always cure people, but there was a small risk of catastrophic complications. I'd never had anybody die, but certainly some people had strokes, things like that. And that's the quality of life issue, the risk. If the surgeon can't tell the patient, you need the operation or not, it's up to the patient to decide how bad the pain is, how much risk they're willing to expose themselves to. That's what I mean by quality of life. As I always say, as doctors, we make decisions, we should make decisions with patients, not for patients. The dictatorial professor knows best is an old-fashioned model, which I think is wrong in the modern world.
Motivation. And let's speak about students' motivation first. It doesn't matter whether it's a postgraduate or undergraduate, or probably it matters, but how do you see now the motivation? Where is it with the medical students in Britain?
In Britain, the junior doctors are on strike. So, I mean, it's not as if everything's wonderful here in England. My experience on the whole is that most medical students and young doctors are highly motivated. They went into medicine because they wanted to treat patients and help people. And then some of them become rather disillusioned as the years go by. I think it's good quality leadership is very important for motivating people. The role of good quality leadership is to hold the team of doctors and nurses together and give a general sense of purpose and vision. We are here to be of service to our patients. We're not here to be of service to the senior doctors' bank accounts. So leadership is very important in motivation. Obviously, if young doctors feel they can't get properly trained, or it's all unfair and corrupt, that's very difficult. It varies. In England, a lot of the young doctors are very demoralized and lacking in motivation, but there are complicated reasons for that. In my opinion, it's not so much money as alienation. They've become small cogs in big hospitals, and there's no longer any real there's management, but everything's fragmented. There's no proper leadership from the senior doctors. Perhaps in Spain, it's at the other extreme. The leadership is too deep, which maybe demotivate people.
In my view, certain things are related to leadership, but certain things are as well related to sort of, probably you can say, social norm or some tendency. We'll give you an example. Recently, the parliamentarian deputy, and she's herself from the system of education. I mean, she's not a doctor, she's from educational system. She publicly said that she would like teachers to read at least 10 books per year, and that would help the quality of their teachers at schools. There was a huge attack on her for that, a huge protest. Why do you want us to read? Books are expensive.
By the teachers.
By teachers, yeah. We don't have time and all these kind of things. And when we look at doctors as well, this thing about reading and the thing about, for example, English, it's not even about leadership. It's about social norm, culture, what it is about according to you, this thing. Because it's as well sort of motivation which should be there, but it's not there, and it's not always about leadership.
Well,
or it is.
No, if they're not motivated, I can't help with that. If they don't want to learn, they don't want to learn. If they don't want to learn English, they're not going to make much progress in medicine. I mean, it depends, I suppose, why do they go into medicine in the first place? And then that becomes a question of how do you select medical students to go to medical school? On what basis are they taken on the training? In England, it costs about at least $500,000 to train one doctor. And quite a lot drop out now because of low morale, low motivation. So that represents a huge waste of money. So selecting people for medical school who really are going to be motivated, who have a sense of vocation and are realistic about what life as a doctor is like is very important. If people are unmotivated, it may reflect bad selection procedures at medical school.
You spoke about relevance. Do I understand correct that the relevance is more about the undergraduate education around all the anatomy, all this thing?
How much you can't, the problem is there are so many different sorts of doctoring, ranging from, cardiac surgery, brain surgery to psychiatry, pathology. There's so many specialties. It's difficult to know how much you can cram into the undergraduate curriculum. But the traditional subjects of anatomy and physiology are really a very limited practice. I'm being heretical in saying this, but they're a very limited practical value for most doctors in what they do.
What are the global... What are the global tendencies? So you said in one of the interviews which we had before that this anatomical theater is not anymore in place. A lot of things.
There's less anatomy. Certainly, in many of the English medical schools, they no longer do cadaveric anatomy dissection. It's all done for them already. I mean, I think I did a year of cadaveric dissection. I think the main benefit of that really is getting you used to dead bodies and death in terms of, so it's a sort of initiation rite. In terms of anatomy, you can learn that equally well from models and modern technology, all sorts of things like that. And surgery, you learn it all over again. You start really from scratch.
What are other tendencies in these changes? What is disappearing and what is appearing?
Katia, to be honest, I don't know, because I have very little contact with medical students. There is a lot more emphasis on communication skills, how to talk to patients, things like that, which is I had no teaching and training at all about communication. But I'm talking to patients who are dying, for instance. That is taught now in medical schools in England, and it's an important part of medical practice. It's not Ukrainian undergraduate education. Certainly should be.
Speaking about the postgraduate, and you were using quite a lot the word leadership and the role of senior doctors and all these kind of things. How should this senior doctor think about himself, whether he is good or not in this postgraduate teaching?
Well, you never know. It's like talking to patients. Patients never dare to tell you whether you're any good or not. They're talking. I mean, if an operation goes well, they're happy. And even if you were very rude and cold with them, they still think you're wonderful. So, but it's the same with teaching. It's very unusual I've been teaching doctors for 40 years, but very rarely do they come and say to me, Mr. Marsh, you're very good at teaching us. And I hope that is because I am, but it's very hard to know, because of even in England, where we're not as hierarchical, vertical as in Ukraine. It's not horizontal, but it's more at 45 degrees, at least in my department. And I'm no longer licensed as a doctor. I don't have a contract in my hospital. I just go in for the pleasure of teaching, unpaid. I've been doing that for quite a long time now, but I know it is appreciated, but none of the junior doctors have ever said to me, thank you very much, or we like your teaching. So I just have to hope they find it helpful.
But how do you reflect about yourself when you, for example, start thinking, am I good or shall I improve something? From which side do you think?
Well, I mean, I talk a lot. My main problem is interrupting people. It's like I've been interrupting you. So my wife tells me I'm the world's worst listener. So when I'm teaching, I always have to, keep myself to say as little as possible, to be encouraging. I'll often make jokes. I will tease people, but I don't criticize them or shout at them and say, that's stupid. I mean, I've made so many stupid mistakes myself. So I try to be more positive and encouraging, but constantly trying to lead them along when discussing problems. But it's like talking to patients. You're trying to put yourself in the patient's position, listening to yourself. What are you trying to achieve? I'm not trying to reinforce my ego. I'm not trying to impress the young doctors with how clever I am. I'm trying to make them into better doctors, above all, to think slowly and carefully and critically. It's a particular problem in surgery because young surgeons all want to operate, as they say, to a man with a hammer, everything looks like a nail. And it's terribly important to get these young surgeons to restrain themselves a bit and learn to discuss the balance of risks and benefits between operating and not operating.
Let's talk about tests and exams a bit. Because in the US, for example, a lot of things are around these famous exams to which everybody is getting prepared. What do you think about exams and What do you think about exams and tests?
Well, I always did rather well at exams. It's my sort of personality. So I'm not the best person to ask. Some people freeze, again, can't cope with the anxiety of examinations. In England now, they use actors pretending to be patients. When I was examined as a medical student almost 50 years ago, it was on real patients. That now doesn't happen. I'm told, I've no experience of this personally, but I'm told the actors are very convincing and they're actually very good at pretending to be patients. Now, clearly with postgraduate examinations, operating, you can't actually examine, you can't watch somebody operating on a real patient and judge them. So you are dependent on the opinions of the people training them. So my own view is exams are a necessary pain, but some of us are lucky and enjoy examinations. Others don't. But I don't see how we can do away with them. In terms of postgraduate examination, I was an examiner for the Royal College of Surgeons for many years for the postgraduate final neurosurgical qualification, which is it's a 3-hour multiple choice exam, a very difficult one. And then separately a clinical examination where actually you do see real patients. And then you're examined by pairs of examiners all day. So it's very fair and very demanding. It's not very difficult. But what is interesting is that it's oral. So the examiners it's all done by interview. And there were educational psychologists who were saying, oh, this is a bad way of doing things. You'll be prejudiced by the fact the candidate is black or a woman, and, it should all be objective. And the verbal, oral, spoken interview is biased and unfair. But in fact, for surgery, when you examine a young surgeon, you can tell immediately whether they know how to do this operation or not. If they've done the operation more than a few times, they will describe exactly what they're doing. If they're simply reciting something they've learned from a textbook, again, you know that. And because you have about 20 examiners, all of whom will see this individual, it becomes very fair. So in fact, oral examinations, in my opinion, are a very good way of assessing practical medical skills for postgraduates. But it needs to be well organized, and the examiners get sent on a training course, so you're not allowed to bully or be rude. You're told how to behave and how to be fair and objective. So it can be done, and I think it works quite well in the West. America is very similar, I think.
The role of all the simulation exercises or simulation, these toys, what do you think about it?
Well, I mean, in neurosurgery, there aren't really very good simulate. There are some, but I think it's important because of lack of experience, and it's becoming less and less acceptable in Britain to sort of practice on patients. It still happens to, inevitably, training involves practicing. But I think simulators are a good idea, but they're never obviously the same as the real thing. And with the real thing, you're much more nervous. Part of surgery is learning to deal with your anxiety and keeping calm and controlled. Some of the, I mean, I've played with some general surgical simulators for laparoscopy. I was terrible, but they were very convincing. You know, I was impressed by them.
With regard the training of the teams, do you think the training is more about one person, or there is a space when it's postgraduate training when it's a team exercise?
It could be a team exercise because the senior person descends. I mean, I learned a lot of my practical surgery from the more senior junior doctors. So everybody should be teaching each other all the time. It's a very important part. Teaching for me is a surgeon. You know, the operating is like a hand in the glove. Every time you operate, you're teaching. And every time when I was a junior, I was being taught. It's a practical skill. It should be like a master and apprenticeship. I always despise senior surgeons who never talked when operating, didn't say what they were doing. I mean, some are like that, but I think it's very sad and wrong.
Books and movies. When I was a kid, I remember reading the Archibald Joseph Cronin books, which were very inspirational. Yeah, I didn't think by that time that I would ever become a doctor, but I felt this inspiration. So apart of inspiration, the books like, for example, the books you wrote, or, you know, the movies which are done about doctors, I don't know, New Amsterdam or whatever, Dr. House or whatever. Is there any space in education, you think, in real life from these movies, or it's only about inspiration?
Movies. I mean, the movies always glamorized. I mean, Dr. House was fun, but had no bearing on medical reality at all. All these obscure illnesses. I mean, it was all fiction. Reading books, I think, is important. I rather sometimes I regret my books because it seems to have encouraged so many young people to want to become neurosurgeons. It wasn't the idea at all. If anything, it was the opposite. But I think reading books is important. I mean, again, particularly from the patient's perspective, if you can find books written by people who've been patients, it can help you understand, because most healthcare is handed out by fit, healthy young doctors and nurses who really don't understand what it's like to be ill and vulnerable in old age, or to be the parent of a child who's very ill. You know, so reading books, I think, can help with that a bit.
Speaking about British professors who teach medicine to the students or to the doctors, again, from the books of my childhood, the medical professors were always this intellectual elite. They would go to the opera, for example, or doing something very high-class intellectual, something and something. What can you say overall now? What is the tendency? Was the dynamic of who were the professors, who are the professors now, how they behave? What are the tendencies?
I think being these posh upper class people is gone now. It's there are more and more middle class people, and there's a big effort for more diversity, people from ethnic minorities, and of course a huge proportion of doctors in England now are Asian or Indian or Pakistani, because it's a very popular profession in Asian families. And I was teaching this morning in my hospital at the morning meeting, and there are about 12 people in the room. Only 2 of us were white English people. But everybody there had been born in England, and there was a Moroccan, a Greek, several Indians, 2 Chinese. You know, it's a very, very international community, which I love. I've always been a great internationalist. So I think in England, medicine is a much wider profession than it was in the days of A.J. Cronin.
Different societies evolve in a different way, and speaking about Ukraine, it evolves in its own way. And the issues of, for example, tolerance, the perception of gender issues, perception of ethnic minorities, diversity overall. I can see quite often that it is an issue in medical community in our country, in Ukraine. Should this be part of education for the doctors, or it's not, or it's back to school and overall culture?
I think it should be part of medical education. I mean, you want to be a bit careful about forcing it down people's throats, how it's taught. I mean, yes, we have what's called a mandatory and statutory training. Everybody in English hospitals has to do the same online examinations, whether you're a consultant neurosurgeon or a cleaner. So it's a bit one size fits all. But in principle, in terms of diverse ethnic diversity, things like that, I think it probably does need to be taught to some extent, a bit, not too much, but a bit.
Human rights?
Because as doctors, we should treat all our patients alike. You know, I was asked if Putin came in with a head injury, would you treat him? And I said, well, yes, is the answer. You know, as a doctor, you should not start, making you shouldn't start making moral judgments as to who you treat or don't treat. Somebody else can do that. But as a doctor, you treat everybody.
Human rights. Should this be a topic or not?
No.
Patients' rights.
Well, patient rights. Yes. I mean, one of the problems in Ukraine is patients have too little redress if things go badly. You know, what can they do? It goes to the other extreme in England. There are so many mechanisms for making complaints and litigation, but there do need to be ways in which patients can complain and protest if things have gone badly. How you organize that? Well, there are many different ways of doing it, but there should be formal mechanisms in hospitals, for instance, where patients and their families can register a complaint. I don't like it, and hospitals don't like it. There have been so many scandals in England over the last 20 or 30 years where patients have suffered harm and the hospital refused to be open and honest about it. We have a duty of candor by law. We are supposed to tell patients and their families if a mistake has been made by law. So in theory, we could go to prison if we don't do it.
The viewer, Angela Gribkova, is writing to you that this is a very interesting topic, and it's very pleasant to see that you really know the problems of the doctors in Ukraine, beginning from the teaching, then to motivation. And we really wish that some changes would be there. And probably in the end, imagine a young, very prominent doctor in Ukraine who is in his postgraduate, for example. What would be the 3 books you would advise the person to read? And who would you like this person to listen to in podcasts or interviews, apart from yourself?
One book I mentioned last time called Black Box Thinking by an English writer called Matthew Syed, about the way we make most progress and learn most from failure, and being open about mistakes and learn. That's Black Box Thinking. And on a similar note, although it's rather a big book and heavy going, Kahneman's book, Thinking Fast and Slow. But that's rather heavy going. But those books to help one think critically. 3 books. Well, I don't like recommending my own books, but I know my first book is unusual among medical memoirs because it discusses failure and how bad one feels about it. And I think it's important for doctors to realize when patients have come to harm that it's okay to feel bad about it, and we all make mistakes. And the thing is not, I think Atul Gawande, the American writer, has written a good book called Complications. And that's a good book, probably better to read than mine, where he says the problem is not to stop bad doctors making mistakes, it's to stop good doctors making mistakes and to see it not too critically. And as I think I said in my talk about patient safety, the critical question is when something goes wrong, and things are going wrong in medicine every day, the critical question to ask is not who is to blame, but what went wrong. You know, what should we do differently next time? And Gawande's book, Complications, is very good on that. So black box thinking, thinking fast and slow, and Complications by Atul Gawande.
And
people, I don't know. I don't listen to podcasts. I don't watch television. I don't watch podcasts. So I listen to podcasts very much. So I can't really advise you there, I'm afraid.
Okay. So we are coming to the end of this series. I hope that we soon will have another's. Again, we had an attack in the night, of course, and again, we are all a bit sleepy because of that. At least in some parts of town, it was very loud. So again and again, would ask you the same. Tell us something inspirational.
Well, nothing differently from last time. I have a Ukrainian flag flying on my roof here in London. Every few months I have to climb up on the roof and disentangle it. But it's the only Ukrainian flag in the neighborhood, although English support for Ukraine remains absolutely solid. There's a general election next week. Ukraine hasn't been discussed. It's not an issue. Support for Ukraine is very, very strong. On a purely personal, inspirational note, I have spent a lot of time in recent weeks working in my garden, and the love of green growing things, which I know you all have in Ukraine, is very important. So despite the bomb attacks, I hope you'll still go on looking after your trees and gardens. Very important for your mental well-being. And I plan on coming back to Ukraine again in October, and I hope maybe I'll meet with some of you then.
Thank you very much, Henry.